Hello students, welcome to week 8, the final week of the course of Psych 10, General Psychology. In this session, we will talk about the hottest topic in psychology that based on we have created psychotherapy, psychopathology, and also sometimes it is called National Mental Health Institute, but honestly it is about the National Psychopathology Institute. So, you have had and you have seen many people around yourself, your community, sometimes in your family, generally in your society, in the world. We know many people with severe, from acute to severe, from acute to chronic mental disorders, from a very popular and very frequent mental disorder, something like that, MDD, major depression disorder, until the very heavy psychotic disorders like schizophrenia, or as we say from 2013, schizophrenic spectrum disorders. So it is good to know as the manager, as a leader, as a member from general population, it's good to know about the signs and symptoms of the mental disorders to find the basic answers to some questions in your mind. So let's go to know about the history of mental disorders. We know from the beginning of the written human history, especially from Aristotle and Galen, we know something about the mental problems. Sometimes they said that these are from the evil. It's about the evil spirits. And as you see, for example, in a movie with the title of Exorcist, we see that some evil spirits enter the body, and after that some people like magicians, and after that some religious people from church, from temple and other parts related to divinity, they come and doing some ceremonies to exit that spirit, that evil spirit, from the body of that man or woman. Until the middle of 19th century. After that, gradually changed, created some changing in the attitude to mental disorders, especially for people with mental retardation. For example, something called that Down syndrome and other learning disorders. And after that, something called that psychotic disorders. With entering to 20th century, everything became more scientific based. From the hard sciences like physics, mathematics, chemistry, and biology, to the soft sciences like sociology, psychology, anthropology, and other sciences in academic universities, we created and we started to use the research methods based on the Darwinism approach to science and gathering information, scientific method, and also entered the mental disorders until the World War II. After World War II, National Mental Health Institute, uh, in collaboration with other institutes like American Psychiatric Association and American Psychological Association, both of them acronym of both of them are APA. Also, the most famous APA is American Psychological Association. But at the same manner, the American Psychiatric Association is called APA. In collaboration between National Mental Health Institute and some associations, especially in this field, with um, American Psychiatric Association, a systematic approach to categorizing of mental disorders created, so-called DSM, Diagnostic and Statistical Manual of Mental Disorders. And in the parallel page, WHO, World Health Organization, created a categorization for all human disorders, not only behavioral and mental disorders, but also for other disorders like, for example, heart disorder, lung disorder, circulatory system disorders. And one part is about behavioral and mental disorders. That system is called ICD, International Classification of Disorders. And after 5 or 10 years, we have a revision on both systems. DSM is completely for mental disorders and behavioral mental disorders. But ICD has a chapter, so-called chapter F, number 6. Chapter F is for behavioral mental disorders. They have the diagnostic codes for insurance papers. And with entering these codes to insurance paper, insurance companies will pay you some money, will pay the, for example, physicians, psychiatrists, psychologists, and other people who are other members of mental health group, especially psychologists, clinical psychologists and psychiatrists, based on the codes, diagnostic codes, uh, insurance companies will pay for the sessions, for the therapeutic sessions, treatment sessions. Now we have ICD, I think at the version of 10. And also we have DSM at the version of 5 after 2013. Many differences has been created from the original version near 1950 until now, after near 7 years, especially in DSM. The major part of DSM is categorization of mental disorders that today we will talk about. Before that, you should know what is the difference between abnormality and illness. We have different approaches to normality. In the contrast, we have approaches to abnormality. And at the same page, we have some categorization and definition of mental disorders. At first, you should know mental disorders are in a spectrum, in a range between two extremes, the least and the highest, the lowest and the highest, in 3 dimensions: severity or intensity, duration or the time, and frequency, the repetition in a unit of time. With these 3 dimensions, for every mental problem, for every mental trait, because sometimes the dimensions of duration, intensity, and frequency, we cannot consider some traits as mental disorders, psychopathology. We can consider all them as personality traits or mental traits or psychological traits or behavioral traits. They are all traits, not problems. But with the higher intensity, with the higher duration, with the higher uh, frequency, we can consider as mental problems, and after that, mental disorders. When you say mental disorder, you should have at least one of these 2 criteria. 1, dysfunction in daily life. 2, distress. Having negative emotion, negative thinking, negative evaluation about yourself or about the world, about your life. Sometimes your function is complete, it's good. You go to the work, you have sex, you earn money, you make some sport exercises or something else. That everybody looks at you from outside and says, no, he or she is good. Why depression? But you come to me and said, doctor, I do everything on time. It's very regular, no problem. It is not observable by others. It is not objective, but subjectively, internally, I don't feel good. It is distress. This person doesn't have any serious problem in function, daily function, but in feeling, yes, he or she is experiencing distress. On the other hand, sometimes people say in the last month, in the last days, especially for example in COVID era, they said that in the last months, in the last days, in the last, for example, period of time, I don't have any good functioning. I'm not so fresh to go to work. I'm so aggressive. I'm so nervous, and other signs and symptoms. It is called dysfunction. So, based on the 3 items, duration, severity, and frequency. We have two types of endings, two types of results, both of them or only one of them, distress or dysfunction. Dysfunction is observable, behavioral. Distress is subjective, it's not observable. It can based on the self-report. You can, as an observer, as a professional observer, you can observe dysfunction in other people. But you cannot look at their emotions, look at their features, their feelings. It should be based on self-report. They say to you by questionnaire, by interview, by their actions, say to you and show to you that I don't feel good. So it is about the distress. I talk about it because these complete preface is not at your book. And I want you to know about the major differences between psychological traits, psychological problems, and psychological disorders. If we can find severe dysfunction or distress for a long time, and with the reputation, with the relapse, it is called frequency, we can call it, yes, it is mental disorder. But finally, it is the duty of an expert man or woman, expert one. It is the duty of It's a duty of a psychotherapist, clinical psychologist, psychiatrist, even social workers, even professional coaches. They are not eligible, they are not certified to have therapeutic diagnosis. When we are talking about the problems, yeah. If you're a certified coach, life coach, relationship coach, sex coach, you can talk about the problems, but you cannot talk about the diagnosis, about the disorders, about the diseases. Why? Because for those diagnoses, at first, legally, you should be eligible, you should be certified. Secondly, you should know about the other theories, other approaches, other dimensions of the mental disorders. Because of that, many people can talk about mental disorders and behavioral problems, but they are not certified, they are not eligible, they are not qualified for talking about the disorders as a professional, not legally, not ethically. So let's go to look at the division, dividing how they categorizing the problems of disorders of mind or mental disorders. Let me share you. In all, also, it is a professional branch of psychology. It is called clinical psychology, and the major part of it is about psychopathology and psychotherapeutic method or psychotherapy method. But in all general psychology book, at the last session, sometimes in the middle sessions, you will find a good approach, a good data about the psychological problems as the disorders, not as only the problems. Defining abnormality, deviation from the average, it is one definition. It is very, very frequent, very usual in the experts to consider the 70% of people, average people, and lower and higher than 17%, the 70% is called abnormal. Deviation from the ideal, you consider, for example, by your religion, by your divinity, by your political approach and other things, you consider some point as the ideal point. Everything before that, after that point is called abnormal. A sense of personal discomfort, it is abnormal. I will talk about distress. The inability to function effectively, we talk about dysfunction. A legal concept, insanity, not a psychological term. Some people, for example, Alfred Korzybski, 1924, Alfred Korzybski, 1924, has a book so called with the title of Science and Sanity. Science and Sanity is the basic book for NLP approach. The very famous quote from Alfred Korzybski is that territory is map is not the territory. Map is not the territory. And he considered your mind, your evaluation as your map about the world, and the real world is the territory. And Alfred Korzybski, with a very deep looking at the meaning of things, meaning of words in our mind, it is very, very powerful book, very, very uh, authoritative book about the science and sanity, with the title of Science and Sanity. What is the role of belief system in interpretation of the world? It is called Science and Sanity by Alfred Korzybski. And finally, abnormal behavior that causes people to experience distress and prevents them from functioning in their daily lives. We have one, two, three, four, five, six approach to abnormality: medical perspective, psychoanalytical perspective, behavioral perspective, cognitive perspective, humanistic perspective, and sociocultural perspective. What is abnormality in medical perspective? Assume that physiological causes are the root of psychological disorder. It is the kind of body and mind connection. It says that your problems because of the abnormality in your brain, chemical abnormality or issues, abnormality and something else. And psychoanalytic perspective says, it is coined by Freud. It says that psychological disorders stem from childhood conflicts based on the Freud's approach to life. And behavioral perspective says abnormal behaviors are learned responses, something like learned optimism or learned helplessness. A cognitive perspective says cognition, people's thought and beliefs are central to psychological disorders. You can find this approach to mental disorders in some approaches like CBT, cognitive behavioral therapy, or RABT, rational emotive behavioral therapy, or information processing system in memory and other parts of problems. Humanistic perspective says that people responsibility for their own behavior and the need to self-actualize. In a humanistic perspective, gradually we enter the positive aspects of human being. For example, freedom, responsibility, right of choice, power, zest, strengths, virtues, because at the ending part, humanistic psychology approach to human being or humanistic psychotherapy or psychology ends to very, very vigorous, rigid science-based, evidence-based science of positive psychology. Positive psychology is more academic than humanistic psychology, also very vigorous and very science-based, very evidence-based approach to strengths of your strengths. And sociocultural perspective, it's a holistic approach to abnormality. It says that behavior is shaped by family, society, and culture. Some scientists in psychology, especially Vygotsky was a Russian psychologist. He died about near, I think, 70 years ago. He died very soon. And he has a very comprehensive approach to human being, especially in mental disorders and development. He says that because of the Soviet Union of Russia, you know that in that approach, everything is relative to the background of your society. It is about your social approach, socialism and communism also. He said that sociocultural or historical approach to human being. He says that all your personality traits are shaped by looking at the elites and by looking at the proximal zone of development. what people you accept them as the elites and you are looking at them, and your history, your culture, your society shape your behavior. Possible application of perspective to, for example, Chris case that we said, you should find a perspective in the case we have talked about. DSM, as I said, the Diagnostic and Statistical Manual of Mental Disorder, 5th edition, 2030, a system devised by the American Psychiatric Association, used by the most professional to diagnose and classify abnormal behavior. You can find here some groups, some categorization of mental disorder: anxiety disorders, somatic symptom disorders, dissociative disorder, mood disorders, schizophrenia, schizophrenia and schizophrenic spectrum disorders, personality disorders are very important in management and leadership personality disorders, and childhood disorders, and list other disorders. Okay. You know that we have many anxiety disorders. Three phrases you should consider different between them. We should differentiate between them: anxiety, stress, fear. And sometimes we can use you can use the word worrying. Anxiety disorder, occurrence of anxiety without an obvious external cause affecting daily function. It is anxiety disorder, the occurrence of anxiety without an obvious external cause affecting daily function. Basically, when you have a long-term worrying without any external cause, external roots, it is called GAD, generalized anxiety disorder. Without any external, any determining factor that you said that I have worrying because of that problem, because of that root, because of that factor. If it is a little more severe, more than worrying, but again, you don't have any uh, clear stimuli for that, it is called anxiety. So in anxiety and worrying, you don't have any external stimuli for your anxiety or for your worrying. If you have a specific external stimuli or internal, but it is a specific, it is clear for you, it is not called anxiety or worrying, it is called fear. Because of that, you don't have any anxiety about, for example, cats, about the animals, about the other things. You have fear. If you have recurrent, repeatable, recurrent, intrusive, recurrent, intrusive fear about something, which is irrational, it is called phobia. We have near 60 types of phobia. So recurrent, irrational, intrusive fear, it is out of also out of your control. It is something like obsession. Obsession is out of your control. You know that it is wrong belief, it is false belief about you or about the world, but you cannot control it. And it is intrusive for you. It is recurrent for you. It is obsession. And also about the fear, it is called phobia. One of the relatively popular, relatively current, and relatively frequent disorders from the categorization of anxiety disorders is the panic disorder, with or without social phobia. Panic attack symptoms may include heart palpitation, shortness of breath, sweating, faintness and dizziness, gastric sensation, and sometimes a sense of imminent death. It is panic attack. The sense of very, very imminent death is one of the worst symptoms of panic attacks. Again, signs of panic attack. Again, what is the difference between signs and symptoms in psychology, clinical psychology, and psychiatric? It's very clear to distinguish between them. What you can see as an external observer, it is sign. There is no need to ask the client, or there is no need to ask the patient. You can see it. It's observable. It is objective. So complaints which are objective, no need to explain for the observer, even for non-expert, non-professional observer. It is called sign. Symptoms are not observable. Symptoms are subjective. You cannot see as the observer, external observer. And also I cannot show you as a person who is experiencing something like symptoms. Symptoms are subjective, internal. For example, I can show you my wound in my hand, but I cannot show you my pain. Pain is subjective. I can report you, but I cannot show you. There is a distinguished line between them: observable, non-observable, or observable or self-report. If there is no self-report, you cannot find any symptoms. Symptoms is only related to based on the self-report, but someone who is experiencing. Generalized anxiety disorder, we talk about it. You have worrying in different situations of your life. It is not all the day, but sometimes the frequency is so high. For example, 3 days or 4 days a week, you have some worrying in different situations without any clear, approved external stimuli for your worrying. And obsessive compulsive disorders, also, it is two types: obsessive compulsive disorder and obsessive compulsive personality disorder. I don't want just now talk about the personality disorder, but the major difference between OCD, obsessive compulsive disorder, is that with the major difference with OCPD, obsessive compulsive personality disorder, is that it is egocentric and ego-dystonic. In personality disorders, you are egocentric. You don't understand that you have problem. You said other people have problem. They should accept and receive treatment. I don't have any problem. It's their problem, other people. So it is called personality disorder because the cognitive emotional unit for assessment or gathering information about the disorders, mental disorders, is personality. When personality is the same unit of disorder, there's nothing to assess, there's no unit, there's no agent for access and gathering information. So obsession, compulsion, a persistent, unwanted thought or idea that keeps recurring, possibly for days or months, it is obsession. And compulsion, obsession is about your feeling, about your emotion, about your thoughts. Obsession is a symptom, but compulsion is a sign. It is observable. It is objective. We can see that, we can observe that. Compulsion is an action, an irresistible urge to repeatedly carry out some act that seems strange and unreasonable. Compulsion will lead to reducing your obsession. Compulsion will end to haven't overcome your obsession. Because of that, when you have obsession as a thought, as a belief, as a feeling, you cannot resist against your compulsion. It says irresistible. It is irresistible urge. Causes of anxiety disorders are genetics, family history, certain chemical deficiencies in the brain because of medication, because of the foods, because of the changing, for example, in your sleep or sexual behavior. A learned response to stress. Anxiety is something different from stress. Stress is the difference between your resources and your demands. If your demands are higher than your resources, you will feel stress. But stress is not anxiety. You have several different responses to stress. One of them is experiences anxiety. One of them is problem solving. One of them is self-focus and other things. Cognitive approach: inappropriate and inaccurate thoughts and beliefs about the world. It is the approach from the approach of cognition, from the approach of beliefs, thought, thinking. It says when you have some uh, deficiency in your beliefs about the world, those beliefs will create anxiety sign and symptoms, especially anxiety symptoms in you, so that in higher sensitivity, in higher intensity and higher severity, it can be called anxiety disorder. These are different approaches to the etiology or causes, knowledge about the causes of anxiety disorders. Somatic symptom disorders. Somatic is means related to your body. For example, when we say psychosomatic medicine, it is the medicine about the relationship with your mind and body. Psychosomatic, psycho for mind and soma for body. Another example is in the cells. We have different components of cells, especially at the major part, it is called soma of the cell soma. That in the center of the soma, we can find, for example, nuclei of cell. Somatic symptom disorders are the disorders, psychological difficulties that take on a physical or somatic form, but for which there is no medical cause. You say to your doctor that I am experiencing pain for a long time, for example, back pain, and doctor order for you MRI or CT scan or other lab tests. Finally, he or she said to you that, sorry, but there's no severe, there's no observable, there is no approved problem in your back, but you are experiencing lower back. It says somatic, it's a somatic symptom disorder. It is a mental problem that show itself as a somatic symptom, as a problem in your body. My PhD is on health psychology. And I know that health psychology talk about the uh, mind and body connection. For example, in asthma, diabetes, in cancer, in HIV, in obesity, in different aspects of behavioral problems, that you can find some severe and serious approach to psychological part. Illness, anxiety disorder, and conversion disorder. Illness, anxiety disorder, it is something that you have always anxiety about the future or present, but not approved. Present only in your mind. You think that I have diabetes. You think that I have cancer. You think that I have psychotic disorder. But you go to the physician and they assess you, say, no, there is no cancer, there is no psychotic disorder, there is no sign and symptoms of diabetes. But you say, no, 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 I'm so anxious about my body and about the future. It is illness, anxiety disorder. And the other one is conversion disorder. Conversion disorder is very, very hard psychological problem, and its treatment also is very hard. Conversion disorder is something in your mind, for example, your fear, your sadness, your anxiety, your stress, your bad history, and other things that convert to psychological, to physiological signs. Psychological symptoms convert to physiological signs in your body. For example, you say that I have always some ache in my stomach. After going to a physician and they have a good physical exam about you and your abdominal part and your stomach and say, there's no serious problem here, but you have some major serious problems in your stomach. And after that, you go to psychologist, especially psychotherapist, which we use for a psychoanalytic approach to, human mind, and after 6 months, you see that there is no pain there. It's good. It's because of conversion disorders. Sometimes of serious physiological problems we can find in conversion disorder. And dissociative disorder. Dissociative disorder is about also sometimes it is called multiple. Some types of dissociative disorders are called multiple personality disorders. You see one person with different personality that none of them can remind the other one. It is dissociative disorders or multiple personality. Also, it is very rare. And now the phrase multiple personality disorder is not a technical, it's not a professional phrase. We don't use it as the psychotherapist, as the psychologist. But in the previous books, previous versions of DSM or other systematic diagnostic approaches to mental disorders, yes, sometimes we use multiple personality disorder. But totally dissociative disorders are rare psychological dysfunctions characterized by the separation of different facets of a person's personality that are normally integrated. Dissociative identity disorder, dissociative amnesia, dissociative fugue, that they leave their home, leave their city, go to the other city, go to the other country, and they cannot remember their basic identity, their basic city. Completely different person with different identity, with different memory. And mentally, it is something like this. There is no lie. It is not that they are trying to show you that I am not the same person. They are not the same person for a long time, for 2 years, 3 years. This is totally dissociative disorder. Um, it is very hard, honestly, it is very hard to talk about the dissociative disorder and causes of dissociation. Also, it is so rare. It's not very common. I have never seen in my near 15 years of professional practice in the field of psychotherapy, also some years in the field of psychiatric nurse. Totally, the summation is near 20 years. In the last 20 years, as working uh, in a nursing position or also psychotherapeutic position in offices and in hospitals, I have never seen a multiple personality disorder or dissociative disorder, person with dissociative disorder. It is very rare. But when you can find it, it is one of the most resistant disorder to treatment. So deep problems. There is a movie, it's an old movie, old cinematic movie, so-called Sibyl. Sibyl is the history, is the story of a girl with multiple personality disorder. If you want to know about the multiple personality disorder, you can watch the movie Sibyl. Dissociating key parts of who they are can help people keep disturbing memories or perceptions from reaching conscious awareness. It reduces anxiety. We do everything for reducing our anxiety, from the defense mechanism to the dissociative disorder. And mood disorders. Welcome to the world of mood disorders. Mood disorders are the most popular mental disorders, and some estimation about the future says in 2030, after cancer, the second popular disorder is depression. Depression is the major part of mood disorders. We have two types of mood disorder, unipolars and bipolars. And the most important disorder in the categorization of unipolar, only with one pole, it means one stage, one episode, one state, is depression. Disturbances in emotional experience that are strong enough to introduce on everyday living. Major depression, MDD, major depressive disorder, so-called MDD. About 15 million Americans suffer from depression. You know that um, the pills of depression, antidepressant pills, antidepressant capsules, antidepressant medications are very, very, very lovely in America. Why? Because many people here cannot find any meaning for their life, only working and working and working. Because of that, fluoxetine or Prozac is the trade name, and fluoxetine is the chemical, sorry, pharmaceutical, this pharmaceutical name for them. Fluoxetine is for the Prozac is fluoxetine. We have some movies, Nation of Prozac, and other other movie about the Prozac. One of them is Prozac Nation or Nation of Prozac, and second one I am not certain about it. It is, I think it may be. Um, I'm a Prozac addict or something like that. So the usage as the OTC, over-the-counter medication in some states of America, Prozac or fluoxetine has the highest rate after the medication about healthy people, for example, for their skin, for their digestion. It is about the getting their function better and better. After that, mood disorders, especially depression, especially medication for the depression like Prozac or fluoxetine is the most uh, relevant, most current medication in the all pills or all capsules or injections you can find in drug stores and pharmacies like CVS and all, for example, Walgreens and other pharmacies. Women twice as likely to experience as men. We are talking about the research findings, different from normal occasional depression. We have three parts. It is called differential diagnosis. The diagnosis that we can find some common signs and symptoms, but they are not the same. They are different. First, sadness. Two, grief-free depression. Sadness and griefs are hard, are problems, but they are transient and they are not disorders. Occasional depression, more intense, lasts longer, and may have no clear trigger when you are talking about the major depression. It is something different from occasional depression or sadness or grief. For sadness or grief, you can find some external or internal causes. Even it may be, for example, your attitude to life. It's an internal cause of major depression, but you know about those false beliefs. You know about those wrong attitude to the world. You can find your beliefs. You can find your felt or mental syntax or mindset. And in many times, in many cases, we can find some wrong and depression making lifestyles. If you want to change yourself, you should change your lifestyle. If you want to change your lifestyle, you should change your mindset. If you want to change your mindset, you should change your beliefs and the emotion based on those beliefs and the behaviors based on those emotions and beliefs. It is your mindset, your attitude. It's the basic part. And after that, you will have sometimes different lifestyles. The second part is bipolar. Bipolar is meaning that you are not experiencing always the depression part, depressive mood. You have two poles, two parts. In the two extremes, one is depression, two is manic phase or mania. Mania, it is you are very, very high. Swings between highs and lows may occur few days apart or may alternate over years. Periods of depression usually longer than periods of mania. It is bipolar, swing between the mania and depression. And what are the causes of mood disorder? It is the basic question because we know that depression and schizophrenia are the oldest known mental disorders. Depression and schizophrenia. So many people were categorized, not only categorized, many people were considered as schizophrenic. Also, schizophrenia is the 20th century word we are using. It is called insane people, for example. Insane people. And other parts, it is mood disorders, especially uh, depression. We can find in the history of human being. Schizophrenia with the other words also, not with the title of schizophrenia, what with the same sign and symptoms, especially their same uh, symptoms. And the second one is depression. Also, it is not based on the orders. We can consider depression the first. These two major depressions, major mental disorders, we can find the sign and symptoms in the history. What are the causes, especially when we can find some family models, family patterns for schizophrenia and especially for mood disorders? Why? Neurotransmitters, serotonin and norepinephrine, it is the first one, related to your body, related to your brain, and genetic factors like your family history, and feelings of loss or anger directed to oneself. Psychoanalytic approach says, yes, when you have some sadness, you have some anger or loss directly to someone else, it can cause major depression in you. Stress of life is a positive reinforcement. So people with it is behavioral approach to the causes of mood disorders, especially causes of depression. And learned helplessness. Learned helplessness is one of the greatest theories about depression, coined by Martin E.P. Seligman. Martin E.P. Seligman, after coining and after working on the phrase and concept of learned helplessness, sometimes he understands that he's not directly working on learned helplessness. His book publisher says, Martin, you are not working on helplessness. You are working on learned helplessness. You are working on learned optimism. So, one of his major books that after that and based on that, positive psychology started to grow is learned optimism. And after that, optimistic child, and after that, authentic happiness, flourish, and now in 2019 or 2018, we can find the Hope Circuit and also the founder of positive psychology. Learned helplessness, a concept which was driven from the experiments on dogs, not on human beings. A learned expectation that events in one's life are uncontrollable and one cannot escape from the situation. It is called learned helplessness. Especially, it is some types of social phenomenon and social problems. And the final approach to the causes of mood disorders is view self as a loser, as a victim, which end to self-blaming and negative self-focus. Okay. Other parts after mood disorder we can consider schizophrenia.